Ladies and gentlemen, welcome to our first of many to come distinguished webinars of the UEMS section of surgery. I'm very delighted about the big audience that is going to watch us today, and I'm also very delighted to announce our distinguished speaker for this evening. It is Roman Pfeifer, who is a trauma surgeon in Zurich at the University Hospital, and he is a dedicated scientist in the field of polytrauma management and has received a lot of rewards for his scientific work in that specific field. I'm very delighted today that he will give us a speech on polytrauma management, historical review, and current discussion. And I hope that you will enjoy his presentation as much as I will. And thereby, I already hand over to Roman Pfeifer. Before he starts, I would just ask you to post your questions if you have any. You can use the question and answer button on the bottom of your screen and then post the questions, and we will gladly be discussing them afterwards together with Roman Pfeifer. The speech will be about 40 to 45 minutes, and then we will have 15 minutes for the discussion. Thereby, Roman Pfeifer, thank you very much for hosting this, for giving us your talk this evening. And please start your presentation.
So, thank you very much and good evening, everybody. So my name is Roman Pfeifer. I'm from University of Zurich in the Department of Traumatology and Trauma Surgery. And I would like to discuss with you about polytrauma management, about some historical background information and current discussion. I have no conflict of interest. My main topic is the definition of polytrauma. I think it's very important to define what is polytrauma, otherwise we speak about different patient groups. I would like to show you some historical background about the polytrauma treatment, show you some cases and the topics of the current discussion. Initially, we're going to speak about the definition. Well, polytrauma, if we speak about polytrauma, we usually discuss about blunt trauma patients. So the patients are multiply injured in many regions, and usually we have some changes or compromises in the patient's physiology, and this patient have a higher risk of morbidity, mortality. And the difficulty is how to bring this, all these parameters, all these criteria together to define a polytrauma patient. This nice review from Australia, from Professor Balak, shows many different definitions of polytrauma. You see the table on the left side, which includes the definition of polytrauma according to the number of injuries. It's there's a list of, I think it's 6-7 definitions with a focus on numbers, and the evidence level is shown here on the right side. It's not a high evidence level. This is a huge list of definition, which represents the threat to life. So in the combination of injuries, also the different body regions, again, we have a huge from 80s to 2000, and all these different definitions from each groups, which makes the analysis and the comparison of the studies very difficult. This is one of the big issues, I think, in the polytrauma research, that definitions are not so clear and different between studies. Another definition is according to the injury severity score, where you have ISS more than 18, 26, 16, and so on. Again, a huge range, according to different study groups and so on. Usually, the definition of according to injury severity score is widely accepted. We have clearly defined anatomical regions. You can classify your injuries from score from 1 to 6, and you add 3 different more severe injuries from 3 different anatomical regions, and according to the formula here on the left side, you can calculate your injury severity score. There was an idea to use a new injury severity score where you just use the 3 most severe injuries. So not the regions, but most severe injuries can be all injuries and extremities, for example. So, and this definition better predicts the mortality, better predicts the multiple organ failure, and especially in orthopedics trauma is better useful. But if you discuss the physiological effects after polytrauma, it's not really represented here in this definition. That's why it's very often under discussion. That's why many experts came together from Europe, United States, Australia to discuss a definition together. And the final consensus was so-called Berlin definition of polytrauma from 2014. And it includes 2 injuries greater or equal of AIS injury, abbreviated injury score of 3 points, and 1 or more additional pathophysiological condition. It can be in hypotension, it can be unconsciousness, acidosis, coagulopathy, or age. All data were taken from German trauma registry, and thousands of patients are included. And so this definition includes anatomical locations, but at the same time also physiological conditions. So it much closer represents the situation of polytrauma patients. And if you have a polytrauma definition which fits to a patient, for example, there's a risk of mortality in this patient and up to 30%. It was calculated in this study as well. Probably we can start one question to the audience. What kind of definitions they use in the department? Do they use a Berlin definition, ISS more than 16, 25, or other definitions? Is it possible to start this voting?
Yes, I will start this question now. You have the possibility now to vote on your computers. Okay, the voting is already going on.
Thank you.
So we leave it on for a little bit. Quite a lot of people have answered already. We leave the others still to think and make up their mind. Okay, there's still answers coming in. I will leave it open for another 5 seconds. 5, 4, 3, 2, 1. Okay. So I hope you can see the results now.
Yeah, thank you very much. So this is very so equal distribution here, very interesting. Usually if we do this, if you ask this question in our polytrauma courses, in the majority of cases, participants use ISS more than 16. This is the most common answer that we have, but this is here only in 20% and 25, also in 20%. Berlin definition is 20%, and the combination of life-threatening injuries like chest, abdomen was even 40%. Very interesting. So you see, even probably in a group here, which is present here, you see that it's not everyone uses the same definition, which is, I think, like I told you before, is a big issue in the polytrauma research. So if you focus on research questions, very difficult to compare the results of publications, perform meta-analysis, because different inclusion criteria, different definitions are used in this publication. So then we can go on. Thank you. So let's go back to the history. And actually, so in the end of 80s and the beginning of 90s, the polytraumatized patient was considered too sick for operation. So in the majority of cases, the tractions was used initially to stabilize the fractures. Patient was in ICU or in a ward, and surgeons started the reconstructions after a while. After this trauma disease, I would say, after the physiological changes gone away, and the reconstruction of the fractures could start. This surgeon from the United States changed the treatment strategies. He published this prospective randomized study focusing early versus delayed stabilization of femoral fractures. Very often, femoral fractures are used as like a sign of major fracture. So it stands also for pelvic fracture, spinal fractures. This is something like a major fracture that needs to be addressed soon. And this prospective randomized studies, he showed that if you have a polytraumatized patient and you fix this in this patient, the femur fracture early within 24 hours, you see that this patient have early stabilization here, and we have polytraumatized patient with late stabilization. We have 46 versus 33. We have a less frequent and less often complications, severe complication like adult respiratory distress syndrome. We have less problems with fat embolism, pneumonia, and so on. So actually, this was one of the first studies which showed that early fixation is very advantageous for the severely injured patient, the polytrauma patient. And using this data, many traumatologists in this time, end of the 90s, beginning of the 90s, sorry, end of the 80s, beginning of the 90s, started to operate polytrauma patients on the initial day of admission. So they did, if, for example, the patient had the upper and lower extremity injuries, they started to do operations on upper and lower extremities, and try to fix all fractures on the first day. And it was a little bit triggered also by the industry, because new implants were on the market, intramedullary nails, other implants, and so surgeons operated for 5 or 6 or even 8 hours, while many liters of transfusions and fusions, and patients developed a complication in a later course. And the same period of time, there was a description of the damage control strategy initially observed or described in penetrating abdominal trauma patients. And it was described by Rotondo, and this patient group identified if you have these 3 different pathophysiological conditions, such as acidosis, hypothermia, or coagulopathy. In this situation, you need to use an abbreviated surgeries to allow the physiology to restore. And after a while, you can perform a reconstruction in this abdominal regions. So, and the idea of it is actually this publication show it. This includes a genetic activation after polytrauma in more than 125 participants or trauma patients are included here in this study. And every red light here demonstrates an activation of genes after polytrauma. You see exactly after 1 or 3 days, there's a huge activation of different genes, and it takes a while, up to 28 days, until the genes are already not activated and reduce and are down-regulated to the normal situation in a healthy patient. So trauma usually leads to like initial trauma and pro-inflammatory and anti-inflammatory reaction. And our idea is that to identify patients at risk and to reduce the amount of the second hit. The second hit could be our surgery. It could be also complications like infections or embolism. And if we reduce the complication rates, reduce the second hit with our surgery, we can identify, we can direct the patient into the recovery and avoid complications like multiple organ failure, like it's here described in this diagram. Damage control orthopedics was described a little bit later in the late 90s by Scalia, and this the idea of damage control and this triad of deaths was transferred to orthopedic surgery, and they could show that actually if you use external fixation or other techniques for temporary stabilization, you can reduce operation time, you can reduce the blood loss, which actually leads to a reduction of the second tilt, and with it, better recovery of the patient. You can see this dynamics in the last, like in the last 30 years. You can see it in this publication from our boss, Professor Papek. He could nicely show that if you have a polytrauma patient with a femoral fracture, again, this femoral fracture is something like represents a major fracture what needs to be treated. And you have the 80s and the 90s here. And you see the majority of cases, 60% of cases were treated with a primary intramedullary nailing or plating. So if you put everything together, 80 and 20, 80% of patients were treated directly and fixed directly after trauma. And you see the dynamics here in the early 90s, it was already a reduction. The rates of external fixation increased up to 30% here in the late 20s. The question is, if you fix a patient with the external fixation temporary, when is the best time for reconstruction? What is the best time for secondary surgery in polytraumatized patient? And there were a couple of publications focusing on this topic. So you see actually the rates for multiple organ dysfunction syndrome are very high if you operate between the day 2 and 4. The inflammation is increased. So at this time, there was a hypothesis that the window of opportunity is very relevant. You need to restore patient's physiology and observe the patient. And after a period of time, like for example, 4 or 5 days, you can start the reconstruction of fractures in the polytraumatized patient. And this was a consensus more or less in this period of time. If you now we're going to our times, and this is a publication from 2020, 2 years ago, from German Trauma Registry, demonstrating the treatment strategies which exist now. And we have a year here, 2002 and 2018, and you see in the majority of cases, patients with femoral fractures are treated. So 51% are treated with external fixation. It started 2002 with 36, 40%. Now we have like every second patient is treated with external fixation. The question, what is the reason? Is it that every second patient in the trauma registry is unstable? Are there other reasons like local factors? It's difficult to say because of this data, but we feel that 50%, it's a little bit like an over treatment for damage control strategy, which is here is used in polytraumatized patients. At the same time, colleagues from the United States demonstrate again that if you fix fractures, femoral fractures, acetabular fractures, spinal fractures, early within 24 hours, 572 patients are included in this analysis. You see that there's a significant lower incidence of pneumonia. There's a significant low incidence of IRDS and overall complications. So it seems to be, again, like before, early fixation is still relevant in patients with so-called major fractures or pelvic or acetabular femoral fractures. Another publication from another group from the United States, more than 1,376 femoral fractures. Again, if you fix femoral fractures as early as possible, within 24 hours, you see numbers here, more than 1,000 patients. You have less thromboembolic complications, you have less ulcer, wound complications, and so on. And again, we have the same discussion like 20 years ago. What is the right way? Early total care on damage control. And we feel in our working group, in our research group, we feel this both strategies are a little bit like two extreme situations, what you can do in polytrauma. You can do early everything, or you can do nothing, you fix everything with external fixation. And this is neglects a little bit the dynamics of the polytrauma. The polytrauma patient have a dynamic course, and if you decide already initially, if you go left or right to one direction, in the left direction, you already probably miss the physiological reaction of the patient, and that's why I think a new strategy must be here used, and not only these two chances, these two dichotomic solutions that are present in the literature. These strategies also do not fit to different trauma systems that we have in Europe and also all over the world, and also geographical regions. So in some situations we have huge distances. I don't know, United States or Australia have a longer pre-hospital phases and times. And of course, in these patients, the decision-making cannot be done only by these two directions, damage control and early total care, because there are another factors play a role in the decision-making. We feel that there must be something in between in these two extreme situations. There must be some dynamic way to decide how to fix the fracture fixations here in this, how to stabilize the patient after polytrauma. We call it safe definitive surgeon, but there are probably also different names what you can use it. For example, to explain what do we mean with it, I have prepared a very short clinical case. So we have this was a real case, I think 2 years ago. So this is a lady, she is 42 years of age. She was had a frontal collision on the way home, and there were two young guys with a sport car here, had a direct frontal collision with his family. And there was also a small child in the car. And this kid went to a children's hospital, and the mother came to our hospital. And after computer tomography, we found the lady a minor traumatic brain injury with minor bleeding. She had a thoracic trauma with rib fractures. She had a fracture of the humerus on the right side. You can see it here. She had the fractures of the distal fracture of the femur, and both fractures of the tibia and the pilon fracture on the left side. So the question is, what we do? What is the next step? The patient, this lady was completely stable. There were no problems with the coagulation, bleeding, hypothermia, and she had a minor bleeding in the brain and thoracic trauma. So what strategy should we use? If you take this post-extreme situation, I would say early total care, it means that you need to fix at least major fractures, femur, humerus, or even tibia on the same day. And it means that you have an operation time here in this lady up to 7 hours, and probably also longer or shorter. But this lady has already in first hit associated with the injury. And then if we operate this lady, try to fix everything on one day, it will be, I think, a huge second hit, which brings this lady in a problem situation. What if you do as damage control orthopedics? It means we fix everything with external fixation. The operation time would be like 1 or 2 hours. Of course, we reduce the second hit, but according to these numerous publications that I showed you before, early fixation seems to be advantageous in this patient. So it means that this lady has a risk for pneumonia, local infections, thromboembolic complications. So this strategy, it's not useful, even dangerous for the patient. And the question is, what we do next? Is it what we actually feel is more useful strategy? What we have done in this lady is that we, for example, started with a fracture fixation, this completely hemodynamically stable lady directly after trauma. We fixed the femoral fracture, the tibia on the left side. On the second day, already fixed the the humerus on the right side, and again another tibia. And after a waiting period of the the pilon usually needs time to swell down, and after 8 days we fix the pilon fracture. But the stabilization of major fractures we call humerus and femur and tibia was already done with an initial 24 hours. So we feel this is our protocol, what we use, we call it safe definitive surgery, actually using the pathophysiological cascades, which we will going to discuss later. You can classify the patient in stable, borderline, unstable, and extremis. In extremis, a patient at risk to die immediately, so usually you cannot do any fixation. There is an ICU treatment required or immediate surgery to stop the bleeding. And if you have a borderline patient, there's a patient in between. An unstable patient, you do definitely damage control, and in stable patient, you try to stabilize at least one fracture And if the patients keep stable, you can even do a second fracture. But usually you avoid prolonged surgeries. And after repeated assessment, after second day and third day, you can already bring the patient for reconstruction. And so we call it a dose surgical load, and avoid like massive second hits in this patient. So if we probably discuss what kind of parameters or indicators of unstable patients with hemorrhage is useful in your clinical practice, what do you think? Probably we can start second question.
Yes, okay, I will start the questionnaire for the second question already, so you can start voting again on your computers. Thereby, I want to remind you that if you want to send any questions or ask any questions, just use the question and answer symbol on the bottom of your screen and post them, and we will discuss them at the end of the talk together with Roman Pfeifer. So people are voting already.
These are like more or less random parameters from the studies, from polytrauma studies. Probably you have also other ideas. Please write down, and the others, something what you rely on in your clinical practice.
Okay, so a lot of people voted already. I will leave it open for another 5 seconds. 5, 4, 3, 2, 1. I will close it now and show you the results. So 70% of people used the admission blood pressure, and coagulopathy, lactate, and base axis shift.
Very nice. So it clearly represents the triad of death. So like expected, mainly focuses on the blood pressure. And very interestingly, the ROTEM was mentioned here, but only by 7%, and lactate seems to be important blood gas analysis. So like I showed before, the triad of death is relevant. And so so the participants confirm the strategy. Thank you. We're going to discuss about it later in my presentation as well. So the question is, which parameters should be included in the assessment of a polytrauma patient? There are some studies which indicate you should only focus on acid-base systems, which if you have a lactate below 4 or 2, it is enough. We feel it is not enough. We feel even if it's dangerous, if you only focus in polytraumatized patient only on one system. That's why we have performed such the analysis, focusing on different systems, acid-base system, coagulation system, bleeding of the patient, and this we called soft tissue damage. It means the presence of brain injury, thoracic trauma, abdominal trauma. And you see, if you add all these systems, you have much better predictions for early complications. And that's why we recommend not only to focus on one system. And like it's suggested by some studies from United States. It's what we rely on in this 4 vicious cycles, as we call in the pathophysiology of polytrauma. So I would like to suggest to go all these parameters, just to give you an overview on what we work and what kind of parameter might be relevant in your decision making. This is a study group from United States, and we actually suggest to use an early appropriate care and focus on acid-base system. I think this work done a good job, and this defining this blood acid, acid-base criteria. But it's useful to identify patients who profit by early surgeries. But it's only one parameter which you should use in your decision making. And in polytrauma. So we all know that we have different stages of bleeding according to ATLS protocols. And if the patient bleeds a lot, you have a reduction of ATP supply according to the demand, and with the time, there's a membrane leakage and depolarization of the membrane, and the cells produce a lot of lactate. And this is what we measure in the circulation of the patient. And that's why the leg depth is one relevant parameter in your decision making in polytrauma patient. But it's in some situations you have a patient which is hemodynamically stable. So you mean you have a normal blood pressure, normal heart rates, but the lactate levels are elevated about 2.5, for example. This is how acute hypoperfusion is defined. So even in the hemodynamic stable patients, lactate levels can be still elevated, and this is a risk factor for morbidity for a polytraumatized patient. This patient having mortality increase, especially geriatric patients have under-resuscitated and have this acute hypoperfusion that you need to identify also initial hours of the trauma. So the blood pressure is of course relevant, but you need to also look for lactate parameters, lactate levels, to exclude acute hypoperfusion in severely injured patients. The next topic is the coagulopathy. And the coagulopathy is, you see on the left side, it's a table which includes all different types of coagulopathy which can be observed in polytraumatized patient. So tissue damage, activation of different systems, ischemia, and so on. And I try to summarize it here on the right side, like a summary of all these pathophysiological reactions. It is a dilution very often. So if you give too much volume to the patient, we dilute all these coagulation factors. We have a consumption, so it means the patient bleeds and loses all these coagulation factors. And we have tissue damage. It means that due to activation and damage of the soft tissue, for example, if you have severe contusions and so on, it leads to activation reactions and with it coagulopathy, with the development of coagulopathy in trauma patients. What we need to keep in mind that if we have a situation with acidosis or hypothermia, so our coagulopathy may increase in this patient. That's why it's very important that we not only focus on acidosis, like I showed before, but also include into the consideration the coagulopathy. If you have this combination, you have polytrauma patient here you see definition as ISS mod 25. This is from US study. If you have a shock and you have a combination here, for example, shock and hypothermia, you have already a risk for coagulopathy of 85%. If you have only polytrauma and hypothermia, every second patient has it. If you have all three pathophysiological cascades here activated, shock, hypothermia, and acidosis, almost every patient has here coagulopathy. So that's why it's very important also to exclude coagulopathy in patient, polytraumatized patient. So in majority of cases in Europe, there is a recommendation to use ROTEM for your decision making. But we did like a survey last year and asked how many trauma centers use ROTEM in the daily practice, and only 50% of our from out of 80 trauma centers used ROTEM for the decision making. Other centers use rapid ANR or other techniques to exclude coagulopathy. But the recent recommendation mainly recommend on our guidelines really recommend to use ROTEM to identify patients at risk and start physiotherapy. And hypothermia, I have already mentioned before, so it's very easy. Very often we forget to measure temperature, especially in the winter time. And in Zurich here in the mountains, we have patients who come to our hospital have a decreased temperature. It's very often because the platelet function reduces. We have cardiac problems, and even in a patient which not bleed, surgical intervention might be dangerous in such patient, and that's why you need to think about hypothermia as well. So what about tissue injury, tissue damage? And this is very difficult topic. We try to, I try to classify it somehow, and we're working on it. But usually we are speaking here about brain injuries. We're speaking here of severe thoracic trauma, abdominal trauma, pelvic injuries. So all these all these regions are associated with the tissue damage and activation of the immune system. And that's why you need somehow to quantify it or somehow have a view on it. And in the case of severe damage in this area, you need also to think about to perform damage control and avoid early reconstructions of the patient. This study is already 20 years ago, but Professor Giannudis from Leeds analyzed here the role of early fixation in patients with brain injury, and also in this patient's early fixation was advantageous, but we need to consider that if we operate early and patient have a high risk of bleeding, we risk also the development of secondary brain damage, secondary brain injury due to additional hypoxia or hypotension due to the bleeding, and this is a risk about 30%. So early fixation is possible, and the patients profit by it, but if you but there's a risk of secondary brain injury in every third patient. That's why you need to be careful and keep in mind that if the intervention is has a high risk of bleeding, well, it takes so long, you need probably postpone it to a later time point. Probably we can discuss now after initial fracture fixation, after initial stabilization, of the patient, how we do when we start with the secondary surgeries, when we start with reconstruction and polytrauma. So what do you think? Is it the absence of SIRS criteria? If you have normal negative input-output ratio, is the pulmonary function very important? Are the vasopressors very important? Absence of coagulopathy, or how do you decide?
Okay, I opened the question for you already, and people are starting to vote. Thereby, once again, I want to remind you, if you have any questions to Roman Pfeifer, to post them in the question and answer field below. Okay. Half of the people voted already. We give them some more seconds.
So there's no right or wrong. There's more or less the discussion. What do you feel is more relevant? And we have a couple of questions after it. So you will see what are the topics, what we deal with it in our department, and try to answer it not only here, but also in research studies.
Okay, there's no more answers coming up. So I end the survey now and show you the results.
Yeah, thank you very much. So absence of SIRS, the SIRS criteria, inflammation is very important. The majority of the participants voted for SIRS. Normal negative input ratio. So it's usually experienced surgeon very often tells if patients already have not so much negative volume input, it means that the inflammation goes back. So vasopressors are relevant to coagulopathy again. So actually, like I told you before, there are many parameters, so not only one parameter. So you can see it here in our responses that so not only one parameter usually is relevant for the decision making. We go on to the next questions. The next question is also relevant. So question number 4. So if you have a patient which needs a secondary surgery, so do you start the reconstruction if the parameters are normal, or if the ICU clears the patient, or you always wait 72 hours or probably longer, or do you respect the window of opportunity? What is your strategy? So if the physiology is normal, you start already, or you just wait a while?
People are voting already. Half of the people gave their answer. I'll leave it for another 5 seconds. Okay, there's the results again.
As soon as the parameters normalize, very interesting result, perfect. So we see it, I will show you the details later from other study that where we also use the same question. So the majority of cases surgeons do not wait anymore, this 72 hours, or do not wait for window of opportunity. Usually the operative, the physiology is normalized. Very interesting result. Thank you very much. Now we have a last question. So how do you sequence your secondary surgeries in stable, multiply injured patients? Do you mainly focus on body regions? So you start with the trunk first, then the long bones and so on, or you start on the complexity. So it's complex surgeries first and then less complex, or do you focus on bleeding and duration of operation, or even experience of the surgeon is very relevant? What do you think? What is in your practice most relevant?
Okay, people are voting already. We have half of the people gave their estimation already. I'll leave it on for a little more. So there's no more answers coming up now. I close it and show you the results again.
So thank you very much. So risk of bleeding and duration of operation, very interesting. So, and according to the complexity of fractures. So recently we did a larger survey in the CCOT Society. And so I think more or less 300 participants, and the majority of surgeons worldwide actually gave the same answer. They mainly focus on the bleeding and the duration of the operation. So this also represents a little bit here the opinion of surgeons. But of course, the complexity of fractures is also plays a role here. Complex fractures have a long, prolonged operation times. So all these parameters more or less important, but the bleeding risk and the duration of operation still relevant factors. So thank you very much for your opinion. So we go on. I would like to present like one final case from our department to demonstrate, to show you or to demonstrate how is the surgical procedure is going on in our department. Probably we can discuss later about the strategy, whether you feel it's useful or not. So we have a patient. This patient is 32 years of age. Is a patient fall from 2 meters. This is a high energy trauma. This patient is intubated. This patient came to us to the trauma bay. This patient has a pressure with systolic blood pressure of 86, and heart rate of 117. Saturation is normal. Temperature is a little bit reduced, but not a big problem. And this patient has unstable pelvis and open elbow fracture. So these are like the summaries, summary of the all relevant injuries: rib fractures, lung contusion, pneumothorax, open elbow fracture, minor kidney laceration, unstable spine, pelvic injury, and fracture of the calcaneus. The injury severity score is here 44, and which is actually a huge number. So this is you see this unstable spinal fracture, this vertical shear injury of the pelvis, this laceration of the kidney and pneumothorax. So I think it is probably everybody agrees with us. This is an unstable, severely injured polytraumatized patient with some hemodynamic instability, and of course this patient requires a damage control strategy. That's right. So this is what we did on the first day. We fix the pelvis here. Usually we use this rescue screws and anterior fixation with this infix device. Due to hematoma and bleeding in the pelvis, we use the pelvic packing, and external fixation was performed of the elbow. And what you see here, of course, prior or surgeries, the thoracic decompression was performed here on the thorax on the right side. But already on the second day after admission, we removed all towels from the pelvic packing and performed the stabilization of the anterior part of the pelvis. And that was done on the second day. And on the third day already, patient was still physiologically completely stable. And so we used this situation, this time period to stabilize the posterior part, of the pelvis, the such spinopelvic fixation and performing dorsal instrumentation here of the spine on the third day already. And on the day 6, this complex elbow fracture was stabilized. And later, I think in the day 8, we performed the stabilization of the calcaneus fracture. So we have we had the opportunity to ask trauma surgeons from Europe, a total 87 from European Trauma Society. And majority of the surgeons were senior attending or head of the department, and the experience was more than 19 years. And like I mentioned before, we asked the question, when do you perform the secondary surgery after polytrauma? In the majority of cases, gave the same answer that participants here in the study and in this survey. So they do stabilize the patient and fix the fracture as soon as the parameters have normalized, and the window of opportunity is so not valid anymore. So the recent strategy is more or less focused on the patient's physiology and not more waiting on time until the inflammation decreases. So in conclusion, there are many definitions in polytrauma. There is no clear consensus, and like we also saw it in our survey here during this presentation. We feel that 4 physiological cascades, 4 vicious cycles, a triad of death and tissue damage are very relevant in polytrauma patients. You need to classify the patient in stable, borderline, unstable, and extremis. Using this, you can somehow classify this patient and plan your reconstruction of the surgery. There are different strategies described: early total care, damage control, orthopedics. We feel these are 2 extreme situations and not useful anymore in the modern polytrauma treatment. We suggest to use safe definitive surgery, and early appropriate care is mainly the idea of monotrauma, and also not useful in polytrauma situation. So we have recently published a book where we describe and discuss all these relevant points. If you're interested, you can have it. And thank you very much for your attention, and probably have time for a short discussion. Thank you very much.
Dear Roman, thank you very, very much for your very, very interesting presentation. There have been some questions posted by our attendees. One of the questions is, what are the, I mean, if you have such a, I'm sure you have a big team in managing these polytrauma patients. What are the specialties that you consider necessary for a polytrauma unit like you have in the University Hospital of Zurich, and what are the specialties that are always coming to a polytrauma case, and what are the ones that you call on demand?
So usually there's, so in our hospital as a trauma surgeon, of course, anesthesiologist, resident and attending surgeon. So we have radiologists in our department who are present, and we have nurses. We are all, in total 6 or 7 persons, specialists are involved in every polytrauma situation. And then the rest is depending on the injury pattern of the patient. Usually if we have if the patient is hemodynamically unstable, we start the stabilization of the patient, perform a damage control. In the parallel, we of course inform all the disciplines, whether these are vascular surgeons or thoracic surgeon, or of course neurosurgeons. Sorry, I forgot the neurosurgeons, of course, are always present in our department in Trauma Bay, of course. So usually call them the resident is present, but attending, we call them if they are relevant bleeding in the patient. Yeah.
There was also a question concerning the hierarchy of the trauma team.
Yes.
How is it organized in?
So we have I think we have a unique system here. So we work very close together with our anesthesiologists. We call it like dual system, and we do every 10-15 minutes, so-called 10 for 10. So together with our anesthesiologist, we go over A, B, C, D, A, B, C, and D, TLS, all the TLS criteria. and discuss together the stability, hemodynamic stability, and the strategy and treatment of this patient. So we also practice it many times in special courses, the dual working together with anesthesiologists for surgical resuscitation and anesthesiological resuscitation.
Then there was also a question, how often are you performing team trainings?
Yeah, so we at least 2 times in a year, we have a simulation center together with anesthesiologists and residents, and we practice like really complex decision making, like how to perform tracheotomies and who is in charge and in complex unstable patients, and together with anesthesiologists, and practice more or less the communication between surgical and anesthesiological team. So this is, we do it at least 2 times in a year.
Okay. One thing that also came up in the discussion, the so-called damage control dogma, as you mentioned, is not valid anymore. It's more a very individual approach that you take between damage control and early total care, which you call standard care surgery. So this is the new way to go.
Yeah, I think I would say, so it's difficult to say it's not valid if the patient is completely unstable. And so it's, according to the trauma registries, like 15 to 20% might have some physiological derangements. In this situation, you need still consider damage control strategies. So you just avoid additional hits in this patient. But as soon as the patient has a some physiological stability or is again stable, you need to go back from this damage control idea and then try to start early reconstruction of the patient. And the patient seems to profit by early fixations, by early mobilization, early rehabilitations. And this is something like an individual approach, focus on patient's physiology and not have a strategy like it mentioned before, damage control, waiting, and then start reconstruction after a couple of days.
One interesting point that was brought up was the gene activation and deactivation during polar trauma. Does this have any therapeutic impact into daily practice or into research at the moment above what we know in polar trauma management? Or can we suspect that there might be any insights coming out in the future soon that could help manage polytrauma patients?
So this is actually a big issue, and in many society meetings, this topic was I think discussed. So of course, every team, polytrauma team, profits by cases. As we have do many cases, we learn from each person, from each patient, even if this patient stable enough. But if you see only a few patients in if the activation is like organized very strong, and if you see only a few patients in a month or in a year, you lose your connection, your experience. And this is a little bit I think which is which is a big topic, I think. So if you have like a broad activation, you need to have, like in our hospital, you need to see every polytraumatized patient, even if it's not so severely injured, but you have the same protocols, you use it every time with your residents, your anesthesiologists, radiologists have the protocols in the head and practice it every time, and they're very familiar with it. But if the activation is very strict and you see only limited number of patients, you lose this routine in your daily practice. And of course, it might be, especially in the patient who are so complex injured, you usually use your routine and you lose your routine, and this patient may do not profit by it anymore. But that is a big discussion. That's probably my opinion. I think that you need to have a broad activation, and if you see many patients, you have also better view and also established protocols. But probably might be other opinions.
Okay, thank you very much, Roman. This was the questions that we got from the audience. I thank you very, very much for a very, very interesting talk and for taking the time to give us an insight about polytrauma management. Before I close the webinar, I want to raise your attention to our next webinar, which will be taking place on the 10th of November in 2022. It will be held by Professor Paul Ridgway, and the title will be Surgical Performance and Fatigue. Professor Paul Ridgway is a professor at the Tallaght University Hospital in Dublin, and is also a very worldwide well-known surgeon. And the next webinar will be held on the 8th of December, but the topic will be shared soon. As you probably know, the UMS is a non-government organization that tries to set minimal standards for medical practice in Austria, and the section of surgery is one of the most active parts in the UMS. And I also want to raise your attention to the EBSQs exams that we offer. The next ones that will be happening is the exam in emergency surgery in February 2023, and also the exam in upper GI surgery, and the deadlines for applying for those will be starting soon. If you have any more interesting information about that, please visit our homepage. And also, if you want to be kept up about future webinars, follow us on Twitter and LinkedIn, or visit our website on umssearch.org. Roman Pfeifer, thank you very, very much for your time for today. And thanks to everybody who took the time and listened to this webinar this evening. And I wish you all a very nice evening and hope to see you again on the 10th of November. Goodbye.
Thank you very much. Bye-bye.